Welcome to friends and colleagues across the globe joining us for today's webinar, Enabling One Health Surveillance and Early Warning Through Integrated Data Dashboards. I'm Dr. Mark Smolinski, President of Ending Pandemics. The idea of data dashboards is not new. From emergency operations centers to various health ministries, data integration for situational awareness is essential. The capacity to which disparate data sources can be brought together in a meaningful way to include both official disease surveillance data and informal sources of information, including social media, public hotlines, and participatory surveillance, is rapidly expanding through local ingenuity, creativity, and passion. Our Ending Pandemics pioneers are truly embracing One Health surveillance and have created integrated data dashboards that work across various health ministries or authorities. My colleague, Nomita Divi, Executive Director at Ending Pandemics, has been overseeing the 5 projects whose partners are convened today to share their knowledge and experiences with all of you. Nomita and all the partners have put several years spanning every time zone to generate the work before you in this webinar. I also want to recognize Jaya Tanda, who is a member of our team at Ending Pandemics, who helped us expand from our initial work in Albania and Cambodia to include Bangladesh, Pakistan, and Tanzania, with co-funding from the Rockefeller Foundation, for which we are most grateful. I now turn the program over to Nomita.
Thank you, Mark, and good day, everyone. We are thrilled to see the number of attendees today. I thank you in advance for your time and attention. We've designed the session today to ensure we hear directly from our partners and allow for questions from the audience, you. We request that you place all your questions in the Q&A field that you can access by clicking on the Q&A button at the bottom of this webinar page. Please go ahead and ask questions as the session continues, as we will collate them as the session progresses, and we will get to as many as we can towards the end of the program. The goal of this effort was early detection of disease outbreaks in animals and humans to prevent epidemics and pandemics. The champions from the 5 disease surveillance teams will engage in live panel discussions on the details of their systems. They will highlight the challenges and opportunities of designing a collaborative and integrative data dashboard in partnership with multiple ministries. So let's start this webinar off by playing our first introductory video.
Disease outbreaks happen every day across the globe. Some become regional epidemics, and others can become a pandemic, as we all now know with COVID-19. But remember, every outbreak has a beginning. The goal is to stop outbreaks before they start. COVID-19 has revealed many weak spots in early warning as a result of inadequate data sharing and visualization capabilities across the world. Health agencies responsible for pandemics and epidemic preparedness rely on data for decision-making for ongoing health threats as well as emerging threats. Different sectors, be it human health, animal health, and environmental health agencies, unfortunately often operate in silos. When crises hit, connecting the dots becomes an even greater uphill battle for timely action. The need for convergence of information across health sectors cannot be overstated. Imagine a world where outbreaks are stopped before they spread, where human, animal, and environmental data streams are able to merge into coherent early warning signals. This is now possible through One Health dashboards, allowing data integration across sectors for quick decision-making, comprehensive understanding of disease risk, and to inform timely, effective interventions.
One Health dashboard is not easy because One Health dashboard, you see it and it's a digitalized system. But to go to this digitalized One Health, you have to go through a process. And first starts with people and with trust among people. And by rules that you have to put that everybody can follow the rules and can build the trust. So trust and the rules are very important to pave the way to create One Health surveillance or One Health collaboration first.
Allow me to introduce our esteemed speakers. Please excuse the brevity of the introductions. Bios of the speakers will be placed in the chat section. So we have with us today Mrs. Chane Sui, co-founder of Kaosang. She has over 12 years experience in co-designing innovations to improve public health, education, and social justice for communities in Southeast Asia. She was instrumental in designing Cambodia's 115 national hotline, which was credited for identifying 90% of the early COVID-19 cases in Cambodia and was the principal means of providing timely information to the public. Welcome, Chane. We also have with us Dr. Mersini. He is One Health expert and veterinary epidemiologist from Albania. He has more than 15 years of experience working in different government positions. He has had several roles in academia and advisory roles, and as well as designing policy frameworks. He has high-level technical expertise in developing surveillance programs and designing information systems. Next, I call Mr. Eric Beda. He is regional ICT specialist and a systems expert with over 10 years experience in designing and developing digital technologies, concepts, and solutions that support epidemiologists and health research scientists in capturing, analyzing, and verifying public health events and engaging with communities affected by them. Dr. Syed Mursalin is CEO of PAC One Health Alliance in Pakistan, an NGO working on emerging infectious diseases, prevention and control. Dr. Mursalin has over 30 years of experience in areas including health information systems, disease surveillance programs, and health systems. He led both the efforts of development and launch of the National Health Information System in Pakistan in early 90s and 2000s. And last, I will introduce Dr. Salim Usman, a physician scientist at the Institute of Epidemiology, Disease Control and Research, with over 30 years experience working in government services with the Ministry of Health and Family Welfare in Bangladesh. He is involved with national guideline preparation for various infectious diseases. He is also the General Secretary for One Health Bangladesh and is a member of the GHSE Advisory Committee. So I thank each of you for joining us on this panel today. We will hear from each of these innovators right after this short clip that highlights the need for One Health disease surveillance and how each of our partners are enabling this approach.
Having a One Health dashboard, it's merging two different surveillance systems. So usually human doctors and public health people do have their own surveillance systems run and operated by them, and the same happens in the veterinary. So those are already existing. The point is not replacing them. The point is having bridges of communication between them and deriving information from both of them into a dashboard where data are integrated and then can be analyzed jointly, and sometimes seeing the data from different kinds of angles and perspectives that each of the both sides can't see on their own.
Creativity, leadership and perseverance have led to the creation of One Health dashboards in Pakistan, Bangladesh, Cambodia, Albania, Tanzania. Various sectors are able to see the same information and track the activities of their counterparts.
One Health dashboard is actually a new innovation in Bangladesh. So we are just having this new system established in the One Health Secretariat to have all the sectors relevant or stakeholders relevant involved. So we started with sensitization of the One Health community. Then we had developed SOPs and guidelines and the manuals which were also developed by engaging participatory of all the relevant sectors.
As we get ready to hear from our panelists, let me call on Eric first from Tanzania. So Eric, can you speak to some of the unanticipated hurdles that you might have experienced when you were setting up this new system, and what did it take to overcome them?
Thanks, Namita. Well, I'd like to share that I think the turnover rate, especially of key personnel across the different sectors, I think that's posed the most significant challenge for us. Because what it meant is that we had to restart and rebuild relationships and trusts that we had previously developed. And this really affected the momentum of implementing the dashboard itself. However, we were very fortunate to have champions within the Prime Minister's office, specifically the disaster section where the dashboard is currently located. And these champions took the leading role in engaging with the various stakeholders and the various sectors, and they made a world of a difference. So I'll emphasize that the importance of working with the right people in the right sectors, with the right authority to convene the different stakeholders involved in the process, that can really make a huge difference in implementing these dashboards. Thank you.
Thanks, Eric. Yeah, absolutely. You bring up the point that Sylvia raised in the introductory video about relationships and trust, and it sounds like that was certainly part of the reality for you. I'll ask Dr. Morsalan next about his experience in Pakistan. So Dr. Morsalan, question for you is, was your experience somewhat similar in Pakistan or different? What was an unanticipated hurdle that you experienced?
Actually, this One Health surveillance was rather a new concept in our environment. You see the surveillance component. There were surveillance systems, but they were working in silos, and there was never an effort to look at what they are doing, and because you see all departments working separately. So this was astonishing for us, and I think, but the good thing is that the sectors were motivated, and when we talked about One Health surveillance, they were very supportive in this context, and they wanted to move ahead, you see. But certainly there were issues and problems. It's making this understand and rolling it up, and initiating this important area of work. And certainly we lacked the SOPs, and there were some issues that we had to tackle to start. Thank you.
Thank you, Dr. Morsalan. Your team was very, very focused on ensuring that you had trainings as well. You spent a lot of time on training. Can you speak to how that enabled these dialogues with the relevant sectors?
Yeah, I think, as I said, that you see the departments were working in silos, and they were having trainings and capacity building in specific areas of their own sectors. But when we had this kind of training, there was mixed gathering from at least from the four sectors. That included health sector, the livestock sector, the environment, and food sector. You see, and academia, you see, universities were also there. So this was a very interesting and amazing experience for us also. You see, me being with the health sector for long, I was amazed to see the commitment and trust of the people for One Health surveillance and training. So that was very important to set a baseline of the people, have the common understanding. That's critical. So that was the purpose of this, all this. We developed this One Health curricula for academies and for, the public health and animal health schools. And those curricula was utilized in the training of multiple participants. And that was the point, where the baseline information, the ground foundation was laid for the development of One Health surveillance program.
Excellent. Well, thank you for that detail. I'll next call on Dr. Mersini. So Kutum, you and Sylvia have worked on the system in Albania for several years now. And as we saw, Sylvia talks a lot about trust and rules, and you did actually as well. What did you find most challenging in socializing this approach and getting it to practice?
Well, I mean, challenges exist in every day. Even within the sectors, there are challenges. So the trust is built by bringing people together, letting them to know each other, and then working together to a common cause. And in our case, for example, we worked many years, even before we had the One Health platform. We worked together by tackling Brucella and anthrax, which are zoonotic diseases. And that gave the opportunity to get people to work together and then overcome the institutional challenges, because there are institutional challenges, there are professional challenges, there are approach challenges, because different sectors tackle different angles of the same problem. And so harmonizing them, it's a challenge in itself, but we did overcome by building trust, by letting people work together. And eventually with the One Health platform now, life is much more easier because the information is quicker and it's less labor intensive. Because I remember we used to get pieces of paper, stick together and share among us, and it took time. But now with the One Health dashboard, data flows are faster and less work is required by people now.
Excellent. Well, really happy to hear that that's actually in implementation and serving the purpose that it was built for, and will continue obviously to grow. I'll ask the next question to Ms. Chanay from Cambodia. What hurdles had you not anticipated, and what did you do to overcome them with your team?
Thank you very much, Nomita. Quite similar experience like our colleagues from other countries. So Cambodia too, like the collaboration between human animal and including also like the environmental, it has like in the context of like in person and not like systematically into like the digital platform. So the concept that we introduce is something that really the starting point of bringing the digital platform to enhance the disease detection. So the hurdle part, I think the first and foremost would be we quite like focusing on working with the stakeholder, human and animal at the national level. We start from the top first. So aligning with the objective and looking at how might we actually utilize the same platform to support both of the case. But at the same time, we also pay attention about acceptance at the provincial level, at the field level, that people will use it. So we also had a separate field visit to assessing the context on the ground, and then to also take an opportunity to also check the whether people having knowledge and skill to adapt from paper to using the digital platform. Yeah, that was the first and foremost that we pay that we take some time to get through. But once after that, with all the leadership support from both human and animal health, things progress step by step, and we're achieving that. Thank you.
Thank you, Chanay. So I really hear from you about the importance of alignment, and that's really something that you, with the stakeholders, that you really focused on, as well as taking it down to the level of the, the people who are very critical to these systems at the field level, and making sure that it's accepted so that it can be implemented. Thank you. Okay, so I will ask the last panelist now, Dr. Salim, the similar question. What has been your experience in Bangladesh? What hurdles challenged you the most in setting up this system?
Thank you. Thank you for having me. You see, Bangladesh One Health initiative started in 2008, but we were not having this partnership, institutional shape. So eventually, over the years, we thought that the partnership is more of a friendship than having something doing about science.
we had One Health Bangladesh, One Health Secretariat in Bangladesh in 2016, but still the partnership was not totally institutional ownership. So what we do in Bangladesh, we took the advantage of this One Health event-based surveillance data dashboard, a cost-effective approach to have all the One Health line departments and ministry on board. That means we took the training a little differently. We did orientation, so there is ownership. We had them, develop the documents which will be required for data dashboard. We tried to have the mindset change, which is very important for countries like Bangladesh. Once your head of the institute or agency changes, complete, change happens. So we thought that if we have an institutional ownership of this data dashboard, perhaps this will a sustainable process, and so that we can continue, sharing. On the other hand, it will be a cost-effective way to have an early warning for the pandemics. So challenges are there, but we are ready to work for the challenges and have the good outcomes. Thank you.
Thank you, Dr. Salim, and I really appreciate you bringing up, mindset shift. And I really think that that is ultimately what is key to recognize. And we heard from all of our panelists about, recognizing the turnover in the sector, stakeholder alignment, recognizing siloed systems. Your team took a very structured approach with focusing on SOPs and MOUs and really further establishing those friendships to materialize into a more institutional structure. And so, yes, I think keeping in mind that mindset shift that you brought up is so critical. So now I would love for us to listen to a short clip on what it takes to socialize this approach and how we might track performance.
Training and capacity building are critical tools to ensure sustainability of new surveillance tools, such as a One Health dashboard.
We have already developed a curricula on One Health and curricula on event-based surveillance. And we have engaged institutes, training institutes of public health, training institutes of veterinary sciences, training institutes of environment would be organizing regular workshops on One Health, on event-based surveillance, on One Health disease surveillance dashboard, and like that. So all that essential components of One Health, essential components of event-based surveillance are part of our curricula, which has been developed in consultation with the multiple stakeholders. Also, Ending Pandemic Group has been helping us to evolve to develop this curricula.
Considering incentives and measurement of progress are critical for tracking performance. Such metrics can help sectors understand where the roadblocks are occurring. One Health timeliness metrics have been built into the country One Health dashboards and are useful for tracking the performance and progress in reducing the time to early detection and rapid response.
The comparison, the milestone, the One Health metric milestone is something new that we actually apply the metrics from the One Health metrics from the ending pandemic to the system, and it allows the ministries to be able to see the progress from one stage to another. For example, from onset date to verification to investigation. So you can see like the stage of progress from one stage to another. So basically, at glance, it helps to provide insight in each of the steps and what action has been taken. So basically, this enabling really helping the monitoring the case from the national level.
All right, so we just heard about the key features of these dashboards, and some that were highlighted were certainly metrics, timeliness metrics. And when I think about all of the dashboards that each of you have built, no two look the same. They're all quite unique and different, and really, focused on the demands of your own ministries. And so, Eric, I'll call on you first. What key features of the dashboard were most enabling to your stakeholders for One Health disease surveillance?
Oh, thanks, Namita. Well, to give you some sort of a background, the situation in Tanzania is that it's such that the human health sector has quite advanced when it comes to digitizing the disease surveillance and in general electronic disease surveillance. And they've got systems in place that capture a significant amount of data. Unfortunately, it's a different story for the other sectors, especially when we're talking about the animal, agriculture, and the environmental sectors. These sectors aren't as technologically advanced yet, and they lack mature systems that can seamlessly integrate with the platform, with the dashboard. So we ended up with a situation whereby most of the data, of the primary source of data, would have been from the Ministry of Health, from the health sector. And that really wasn't able to match or merge or bring in the concept of sharing of data if only one sector shares data. So during our development of the dashboard, we also had to incorporate features that allowed us to collect data directly from the public using various methods like SMS, using Apia Data mobile app, USSD, chatbots. We integrated with WhatsApp and Telegram. Also data mining from Twitter feeds within the geospatial, within the radius of Tanzania. And another key feature was that we also employed or established a call center whereby the public would call directly in and report business information. That now these information was shared on the dashboard and it served as alerts with the different ministries responsible for these sectors. So it has been proven to be incredibly valuable in helping these sectors to initiate investigations and take appropriate actions as they share the data across. Thank you.
Thanks, Eric. So I really hear about meeting the differing needs of these sectors and making sure that there's a variety of access points so that all of the population can access and report to all the ministries for decision making. Great. So Chane, in the video, I hear you talking about some of the capabilities of your platform. You talk about metrics, but what are the key features of your dashboard that you find really enables your stakeholders in One Health disease surveillance?
Yeah, thanks, Nomita. So the platform itself, so we were looking at bit two. One is like the data is entered by from the field. So once they enter the data, any of the suspect or new of the outbreak event, that means that will go to the system and the national can see it. And the main function, I would just like other things, but I think I'm going to focus on the main things there in the dashboard is on the timeliness and milestone and timeliness metrics that we actually following the ending pandemic timeliness and milestone and timeliness metrics, and that actually building into the system. So when a new case happening, that the case center will be locked, and then when the progress updates, when the field people, field officer go for investigation, verification, the progress of it can be seen, by all the teams. So that is really, I think it's one of the things that are really powerful in terms of information and how turn the dashboard presenting it. Mm-hmm. And another part also, I think that the ministry, it's an agreement between the Ministry of Health and Ministry of Agriculture. They agree on certain disease, certain infectious disease that they would share in real time when the new case happening from the field. For example, if there is rabies, H5N1 falls into the case of the new disease detected, the data will automatically share between their counterpart. So that will speed up also kind of like collaborations and looking at whether that's actually in their area, and that will help the decision maker in the prospect ministry to take action with their team.
Great. So you really talk about ensuring that, or at least the list of disease really helped bring further agreement and efficient sharing on specific disease topics. We did see that across several of the countries as well. So I'm glad you brought that up. And really, I did hear you say, and I know your dashboard, and you have these beautiful visual charts with timeliness. And so it sounds to me that that's really enabling or incentivizing the different sectors to perform so that they are more timely in the various tasks for disease surveillance. Thank you for that clarity. So Dr. Salim, I'll ask the next question to you. What were any low-hanging fruit that facilitated buy-in from the various sectors for this approach on One Health surveillance?
Thank you. So I will answer you a little differently. That is, Bangladesh data dashboard has two unique things. It is not only a visual dashboard, it is also a management dashboard. So that if you go to the dashboard, you can have a public view of all the events or incident happening in Bangladesh in infectious disease. It's open to everybody. But when you have an event-based surveillance or outbreak investigation, then you have some outbreaks which the government might think that they will release it a little late. So any sector, they can block even from other sectors to view that, but they can, again, open it for other sectors to see. Again, they can open it for the public view. So we are open to any disease happening in Bangladesh, but not all people, especially specialists or public, can see it very quickly. So they have to wait till the concerned department agrees. Now, one advantage in Bangladesh we have a One Health Secretariat which has a interministerial steering committee which has all line ministries representation. So since that interministerial steering committee is governing the data dashboard as well, so sharing the data between the sectors is perhaps a little easier for us. But yes, it's a challenge. You're going to right away open it for the public. Thank you.
Well, thank you for giving that insight into how your system actually has layers of visualization and who can see what at different layers. And also that your system also enables the tracking of event-based surveillance as well. And so as you can see, all of these systems are quite unique and different from each other with the same underlying principles. Thank you, Dr. Salim, for that clarity. Dr. Mursalan, I'll bring you on. In the meantime, would you be able to answer the question about what advice would you give to a group trying to build a new One Health surveillance dashboard?
Yeah. I think this is a very good question. I think, we need to follow some steps, you see. The first important thing is to, like the demand generation, you see. You all already talked about it, you see. This is very important. Creating, interest of the people, relevant stakeholder, policymakers, the planners who have to start and take the initiative. And then the contextual analysis of the local situation, stakeholder analysis is doing what. There are several projects and programs which are like very close to each other, but they don't know. They're taking similar steps and doing similar kind of a job, but they don't, not conversant with each other. So there has to be a very strong platform where they get together. And that platform should not be like ad hoc system for the project period, but it has to be a regular mechanism that the technical leads of various sectors, they join on a periodic basis, like quarterly basis or something, to discuss the developments in this context. So it is a continuous process, I must say. This is not a one-time job. This is a work in progress, and this is just the beginning that we have laid in, at least in Pakistan. And a lot more is yet to be done regarding this, the data consolidation, use and joint decision-making, joint planning. I think that should be the next phase, to roll it over and, make it really a useful exercise. Thank you.
Absolutely. I'll have you unpack that a little bit more. So what do you see as the immediate next steps for your team as you've as you've identified, the need to roll this out further?
I think a good thing is that we are, as far as the one that dashboard is concerned, we are quite respected in our area. We know people, you see, whom to work with, and they are conversant with our work, and you see the collaboration. We have a lot many supporting hands, MOUs with the ministries. For example, recently we had a good long-term MOU with Ministry of Agriculture and Animal Health, you see, and probably they will give us support in regarding the, you see, promotion and you see the further development of this dashboard. So this is ongoing, as said, so it will take its time, but there are some phases, but it certainly needs, you see, all programs need some kind of leadership, you see, because it's not automatically being done. You see, somebody has to, after any new project, you see, if they really want to get it a successful note. Thank you.
Excellent. Well, I did hear some key things from you about, obviously the trust and relationship. It's a theme that really comes back again and again. Leadership, so important. And something I think that we should all remember is these efforts take time, a lot of time and a lot of dedication, especially as Eric brought up, the change and turnover as ministries go through these fluctuations. And then also recognizing, as we heard from each of your systems are so unique and different, and that it's not a one size fits all, but really understanding what are the requirements of your stakeholders and building accordingly. So I will note here for all of our attendees that the demos of the various dashboards for each of our partners is available and has been made available on our Ending Pandemics YouTube channel that we will share with you at the end of this meeting. So please be on the lookout for that, and you will really get a view or a glimpse as you look into those films about how these systems are built and the intricacies of those platforms. So now let's play this last clip that we have prepared for you before asking our panelists our final question.
Tanzania to promote digital sharing of information from the sectors. This is the current actually project I'm working on, where we coordinated by the Office of Prime Ministers to be able to actually coordinate digitally, sharing of information from public health, animal health and environment. And therefore we have like a common dashboard shared by all these sectors so they see in real time. This has actually helped very much because we had in year 2017 another outbreak of Rift Valley fever, where it became a blame game because it started actually in cases in animal health sectors, but they actually didn't report to the counterparts in human health. Therefore, it became a blame game. So this time we are doing away with the blame game. We want to share information well in advance, share the early signals so that we can actually help to push each other and therefore actually respond in a timely manner.
Right, so we just heard Ezran talking about doing away with finger pointing between sectors and ministries, and by adopting a coordinated One Health approach to really facilitate One Health surveillance. He gave us a really clear example. So now I'll ask all of my panelists one question. Thinking back to the days when disease surveillance was more disjointed and manual, what can you say is different because of the dashboards? And how do you think they are going to help find outbreaks faster or impact the speed of response in your countries and globally? And so I'll kick off by bringing on Dr. Salim to answer this question.
Thank you. This point we thought initially when we started to having this dashboard concept in our One Health Secretariat and IDC, because we know once the fund is gone, sometimes these programs are gone. So we started to develop these things, having all the sectors heavily involved. Like eventually we went to all the sectors, my director, Professor Tamina Shireen, and technical support from you and other people from Ending Pandemics. We went to Department of Forestry Livestock, Department of, our DG Health and other departments, so that they help us build this dashboard. So they can say that, yes, I put this one there. So yes, I am interested to go on with this. Not only that, we help them to develop, apps based in mobile reporting system, early reporting, just for information. That was also built by direct from the 3 departments of One Health. And they eventually helped us to develop that, initial information system for the dashboard, so that the One Health Secretariat can coordinate a One Health response outbreak investigation or individual sectors outbreak investigation. So it's more of a ownership. And for this, now people and different departments are thinking of having, in the field, community participatory surveillance, and so that they can have more people involved in the community, not only the government people, so that early warning is really a business and science. Thank you.
Excellent. Well, I'm so thrilled to hear that this dashboard is initiating all kinds of other collaboratives and mechanisms, and that you're really focusing now on community participatory surveillance, as well as certainly, thinking ahead with developing this app to facilitate all of the players as well. So Kutim, I will ask you the question again, in terms of these dashboards. What do you think, what difference do you think it's going to make, and how are they going to help find outbreaks faster or impact the speed of response?
Yeah, I mean, in our point of view, a dashboard and all the technology involved with the dashboard related to data capture, it's not just the technology, but it's also a way of doing our work to find outbreaks. So we implemented different sources of information. Apart from the traditional surveillance, which is case-based surveillance, we enhanced the dashboard with event-based surveillance, which collects information from the communities, because those are the first ones which see any issues, especially in animals which are either dead or sick, or even outbreaks in humans where they got a cluster of their relatives or co-villagers sick, so they can report, meaning that we get a signal far beyond faster than the usual case-based surveillance. In addition, we enhanced the dashboard with media scanning. So we have a scanning of all media about potential outbreaks for 8 priority diseases in Albania. So that those technological advancements helped to react or to bring the information faster than you even get a case. On the other hand, a case-based surveillance, when integrated, are very useful for the both sides, for both services, because a sick animal, although there is no sick humans, if the disease is zoonotic in the animals, that's a bell ringing from the human health that something is ongoing, so it can be considered as an event. And the same happens with the zoonotic disease in human. Of course, there is a source animal, so we have to start an investigation and find it out. So we vice versa help each other to find cases faster, and with the help of the community, we have more eyes and ears on the ground.
Absolutely. So really, I hear you talking about a new way of doing surveillance, and you're really talking about this bidirectionality that impacts not only early detection, but potentially a prediction of something that might happen in human cases, right. For example, when it comes to zoonotic diseases, but really the priority diseases, or having that priority list as well, is really helping both sectors to work together. Absolutely. And so thank you for sharing that perspective. I'll ask Chane, if I could bring you on the screen now. What do you think the impact of these dashboards are going to be?
Yeah, like if you thinking, I'm just when you asking that question, like I was thinking in my head, what without this, thinking back, what would it be? If you talk about like informations and the speed to compete with the transmission of the spread of the disease, right? So what we're trying to do, comparing to the traditional one, manual one, where people would call, the information passed on from one to another. First of all, it could like multi-layer reporting. So whereas in the system, like the data report enter directly from the field, so that everybody sees like the data that coming out from that. So there is no filter of that, and the speed of information itself is faster, and in organizing manner, in a way that you can actually monitor, track, looking back at the history. Whereas before, we would be very difficult to have such a discipline, and the data that might be captured in a different mechanism, and not to talk about when would be the time that we can actually having the format that we can actually share, and right now the decision making, the data sharing is real time compared to now. And another thing I haven't mentioned earlier when you asked me is that in the dashboard itself, we also build in connecting to the medicines, where basically bringing the information about like the media, detecting like providing the information about the media related to the relevant disease and so on, that each of the ministry monitoring. So of course, in short, the system, it helps both the human and animal health ministries to monitor the event-based disease surveillance faster, in a mechanism, more organized coordination with each other, and also enhance their capacity also with the media information that alert on the dashboard itself.
Great. No, I love that you flipped the question and you thought about, okay, well, what if I didn't have the dashboard? What would life be like? And so it's clear to me that certainly, you know, there's this no filter, which means you won't lose, you know, some reports along the chain of information flow. I did hear that for sure. And then I appreciate you bringing up the event-based or media monitoring through the use of Medisys. So that's another data source that all of your ministries can use to track diseases in your country and regionally as well, also impacting speed. Excellent. So I'll bring on Dr. Morselin to talk about your opinions on what is the impact of these dashboards from your perspective.
I think this is a wonderful tool, and I think this is really a revolution, you see. We have already worked, I myself was a part of it. You see the manual system that we had, and it was just to make a comparison with the current scenario. It's amazing and alarming, you see, because the issue started with the data capturing, its transmission to some level, and then its circulation, its integration. I mean, there were several issues there, you see. Again, because at that stage, we were only talking about the health sector. I mean, I was in the health sector, you see, but now you are, if you're talking about One Health surveillance, you have to look at the MIS systems or the surveillance systems or definitions, you see the protocols, the frequency, so many other things of the elements of the other surveillance systems as well. So all those, I mean, issues, features have now become possible. You see, and there is because previously there was no chance in getting it interoperable. It cannot share, we're not able to share information because of a number of disparities between the two systems. Because now we can work on removing these disparities, and we can make make something, draw something common from multiple MIS systems. So there is a great possibility now, and this then can also be consolidated, analyzed, and you see used for predictive analysis, and you see used in planning and joint planning and There are so many avenues now available with the evolving technologies. And really, it's amazing for us. You see, thank you.
Thank you, Dr. Merson. So yes, absolutely. This is a step forward in bringing these systems together and uplifting the systems that may not be at the same level. So I totally appreciate that comment. Eric, last but not least, I'd love to hear your perspective about how this might make a difference.
Well, I really share the sentiments of my fellow panelists. And from my perspective, I think the journey of implementing the dashboard has had a significant impact, especially in terms of raising awareness about the importance of sharing information between sectors. Consequently, the Prime Minister's Office has actively been pushing for integration of more sectors and departments to integrate with the dashboard. Just a couple of weeks ago, I attended a meeting that was convened by the Prime Minister's Office, whereby they issued directives for all sectors and departments that collect data related to public health emergencies. These includes organizations like the Meteorological Center, the Police Force, the Food Regulatory Authority, and many more. I think there are like 20 different sectors and departments. And they're all urged to integrate with the dashboard, with the system, integrate their systems with the dashboard so that they can swiftly share any information that could enhance public health safety and the overall well-being. So from my perspective, I think like this dashboard has acted as a catalyst and more in sense like an eye-opener here in Tanzania. And it's heartening to see that the government is taking full ownership in making plans to continuously enhance the system, enhancing the platform, and especially coming from the Prime Minister's Office, the disaster section, whereby their main role is to be able to coordinate the response to these various events and various health events that are coming into play. So I think the journey in terms of especially the engagement process and the awareness process, that has really helped in terms of impacting the awareness and the importance of sharing information between the different sectors. Thank you.
Well, that's really impressive, Eric, to hear that this has certainly been catalytic, but really it's breaking down the barriers to several more groups and sectors to really facilitate the well-being of the community. So the possibilities are endless is what I'm hearing after hearing your response. So with that, now let's open up the session to question and answer, and I'd love to turn it over to Dr. Mark Smolinski to facilitate the audience question and answer. Over to you, Mark.
Great. Thanks, Nomita. And thanks to all the panelists for really very interesting conversations. We have many questions that have come in during your panel discussions, of which I've tried to curate, and we'll get through as many as we can. I want to remind the audience that our panelists are willing to share their emails, and they'll be put into the chat now. So if we don't get to your question, or you have a question specifically for one of our panelists, you could email them directly and they'll be happy to respond to anything we don't get to during this period. Just a couple of things that we got several questions about recording this webinar. Will it be made available? And yes, if you're a registered participant, you'll be notified when the recording is available. We will also post it on our YouTube channel. People have also asked about subtitles, which we had on the videos that we created, but we will plan on adding subtitles to the webinar at the end when we can compare it to the actual transcript and make sure that no errors are entered into doing that. We opted to not do it live for that particular reason. So those will be available. Dr. Merselin, we had a question directed to you that I'll ask the person to email you directly now that they have your email, because it's about training resources specifically in Pakistan. We had two audience questions early on that some of you may have answered in the course of the time, but others asked the same thing. So I'll just make sure to throw this out to the panel. People are very interested in exactly like which data are being shared? I know we're going to have videos, they have details, but if you could just give some examples of, specifics on what kind of data are being shared between the sectors, which diseases, does this include emerging diseases, in addition to what we've heard a lot of examples of zoonosis, as well as like what the platform is built upon. So it's a lot of things that have to do more with like the structure of it, but maybe just quickly, if people want to share perhaps like some unexpected data that you're sharing on your platform that the audience would be interested in.
I mean, in our platform, we share different kinds of data, and this is also one of the challenges for data interoperability, because data can come in different time spans and in different grains and different formats. What we share between sectors, it's case-based data for a specified list of infectious diseases, which are mainly zoonotic, because there should be a common interest. Of course, non-zoonotic diseases are not shared from the veterinary, and non-zoonotic diseases are not shared from the public health. But we keep also data from health events, which are somehow disease agnostic, if we wish. And then those events then verify to a certain disease. So there is also the potential for sharing data for sudden death or sudden disease with unknown etiology. And that's helping for the future disease X to know far beyond than we name the disease. So that's the kind of data we do share. For the media scanning, we have 8 priority diseases that we do collect information, and we share it both sides, and both services do their own investigation to verify this media rumor. So, I mean, as you can see, the data standards and formats are different. And that's a big challenge to accommodate all of those data into one dashboard and also synergize them, because that's the point. Sometimes we start from the unknown, like a health event or a media alert with no disease, and then we follow through until we name the disease. So it's a continuum of processes and actions taken by both services to find which disease we are dealing with when we have alerts from the media or health events reported by the community. Meanwhile, for the case-based data that we do share, I mean, those are pretty good data, are standardized data, the traditional surveillance systems, which are easily joined by time frame and by geolocation. So we do a time and space connection between those kind of data. Thank you, Mike. Over.
Great, thank you, Kutum. Chane?
Yes, thank you, Mark. So for Cambodia, the ministry share the events between each other. Like for the human, Ministry of Health share 8 events that related to infectious disease. So any sort of event that fall into that 8 disease, it will be shared with the Animal Health Group, the Ministry of Agriculture. And for the Animal Health Group, also they set to share event related to five disease with the human. So so these are the decisions by the ministries themselves. And I believe this also in the future it might change as well, you know, as like new disease emerge and the decision of the ministry for the change in the future.
Great, thank you. And we'll take one more response on this question and then move on to the others. So Dr. Salim and Dr. Merselin, I'll get you with the next question for sure.
Thank you. So in our data dashboard, we have 2 parts. One is, event-based, that is outbreak investigation, and one is indicator-based, that is routine surveillance. So since the event-based or outbreak report comes and sometimes is not real time, so we also provide all the common infectious disease in our indicator-based surveillance, and people can see through the data dashboard in the public view. And that is, routinely updated as soon as possible, perhaps 2-3 weeks, the gap is there. So people can see these 2 things. And we have a connection with the other sectors, especially the Department of Livestock. So since their collecting system of data is different from data dashboard, so we have made it a different approach. So they give us the data which can be uploaded in our data dashboard so people can see it. So you can always see data uploaded in our dashboard. It might be event-based, it might be indicator-based, but it'd be for sure very useful. Thank you.
Great, thank you. And Dr. Mercelin, I'll let you add to that, but let me add another component to the question that you may want to respond to as well, and for others to think about. So in addition to some of the data sources we talked about here that we're hearing about in the human health, since this is about One Health, people have interest to know how much like environmental data, so like data from protected areas from SMART or Earth Engine to look at more environmental things, as well as we have questions about wildlife, since we know wildlife surveillance is, severely underfunded. Are you getting any, or what kind of data are you getting on wildlife as part of this dashboard? But feel free to answer the question about other data sources too, Dr. Mercelin.
Thank you. So I've already explained that you see as server systems are concerned, you see the public health server systems are comparatively better structured and better established compared to even the animal health server system. You see that there is an animal health server system, but it's not as good and as established as the human health server systems are. But the environment and you see the food components are really very weak, you see. And there are only very selective indicators that are being captured there, you see, that's right. And again, in our case, we have like two components. One is the indicator-based surveillance dashboard, which is based on the, you see the surveillance, regular routine surveillance information that we are capturing from multiple sources, from the health sector and the animal. At this stage, we are only focusing public health and you see the animal health sector. We are yet to talk about, you see, include environment and wildlife, something like that. Thank you.
Great, thank you. Anybody else want to comment about environmental data or wildlife?
Yeah, I can comment on that. As part of our platform, we also attributed to receiving information directly from the public. So once in a while, we might have people calling in or writing into via USSD saying that they've seen a number of wild birds, maybe dead on the beach, etc., etc. So that's the only input that we have, especially for wildlife. But we don't, as you know, currently we haven't yet integrated with the platform from the wildlife sector. So all that we get from the different, let's say from the environment, from wildlife, or even from other sectors is coming directly from the public. And the way we built our platform is in terms of once that information is received at the Prime Minister's office, the One Health section in the Prime Minister's office, what they do is they look through the data and based on what has been reported, they select which ministries or which sectors that information is shared with. So for, let's say, if something comes in from wildlife, they will select maybe wildlife, animal health, and also human health for them to be able to see the data, and so that the different sectors, those sectors could actively initiate some kind of response to it. Thank you.
Great. And Kuchum, you want to add to this?
Yeah, I mean, as you mentioned, wildlife surveillance, it's underfunded. In our case, it's under the remit of the veterinary services to diagnose cases in wildlife, because also OIE or WAHIS nowadays mandated the veterinary services to trace back wildlife surveillance. But this is a big challenge for us, to be honest, I mean, because vets are more near to farms rather than wildlife. We have incorporated recently the rangers of protected areas just to report any die-offs of wildlife and then cross-notify the vets to if they have capabilities to collect samples and try to investigate. But this is in very early phases, but I think it's the right path to follow. Thank you.
Great, thank you. Okay, so I'm going to combine a couple of questions here because they're semi-related. So We had questions specifically early on for Bangladesh and Tanzania, but I think it applies to most people. They were curious about how long did it take to get the various stakeholders on board with the One Health dashboard, and also who has access to these dashboards now that they're built. Over.
So, as I said earlier, that One Health practice in Bangladesh actually started in 2008. Was to have an institutional shape, it took quite some time. And in 2016, we had One Health Secretariat Bangladesh. So that is the, center point for having governance of our all One Health activities. So since establishment, we needed a ownership of this institutional shape. So we had this One Health EBS data dashboard. And anybody can get access to it except the internal part, which is management part of the respective sectors of One Health line ministry. Otherwise, the public view, it is open to all. You can just go and watch it, no problem. All data are there. And the owner is now One Health Secretariat, which has representation from all the One Health line departments. That is forestry or wildlife, animal health, that is DLS and public health. So ownership is Government of Bangladesh. Anybody working in One Health has access and they can use it. No problem about that. So we want to make it more sustainable and more easily accessible, so it is useful for the people. And when something is useful, then definitely it will be sustainable. Thank you.
Great. Anybody else want to add on that point? Eric?
No? Yes. I would say, for the system, the platform in Tanzania, it took well over a year and a half, I think slightly more, to build and to and to deploy. I think the main, and as we described earlier, the main sticking point is, I think, is the building of trust and engagement. And for our case, it was very, very helpful for working with the Prime Minister's office, because they have the authority to convene the various meetings with different sectors and different departments. So it became a little bit easier in terms of being able to convene different sectors, ministries and different departments into one room and have the awareness and have those discussions to build trust, to build a disease or data sharing list and the various SOPs that are built into the platform so that data can be shared across. So I think to add on to that, I think everybody, the way it's built, anybody who has been tagged on the particular event, on a particular disease, can see the data, can have access to the data, and currently it's only open to authorized officials within the different sector ministries. Thank you.
Great. I think we have Dr. Mersulin next, and then Chane and Gautam.
Yeah, thank you. As I explained, that we have two components of our dashboard. One is for the indicator-based, as event-based service. The event-based one is mostly media-based, as already explained, and it could be accessible to general people. It's not, whosoever is interested in this, like academia, like departments, and they can have it. It has recently been developed, and we are in this, process of popularizing this, promoting this, But as far as the indicator-based is concerned, there are the regular surveillance systems, information coming from departments. So the prime audience of this particular information are the decision makers, the policy makers, planners, and project managers of. Initially, this is based on livestock and the public health. So all those managers who are responsible for taking decisions for joint planning, for joint actions, so they are being provided with this information. It's not very widely circulated at this stage, but let's see as we evolve it. We may be making further decisions on that.
Great, thank you, Chane.
Yeah, thanks, Mark. The system in Cambodia, basically, it's not like for public use yet, right? Because it's for the event-based disease surveillance. It's access used by the Ministry of Health and Ministry of Agriculture, the national and the provincial level. And right now, looking back, like the question about like how long does it take us to onboarding and designing. So I would say it's about like the first year that was our concentrations of like working with all parties, stakeholders, and even with sub of each group itself at the national level, designing indicator that fit for their human health or the animal health. And also including the working in the field also to ensure that we understand that the field user can use it, they have the resource to use it, and prototyping during that first year period. So I think the first year period is a very critical moment. Yeah.
Great, thank you. And Kutum.
I just wanted to share a different angle from Eric's end, because Eric had a top-down approach, or at least that's how it works in his own country. But we have a different experience in Albania. We have a bottom-up approach. And this is also maybe a recommendation for all the participants in the webinar. If they want to build not a dashboard, but to build a true One Health, we choose in Albania brucellosis, a real problem of both sectors. And we took this as a flagship disease to tackle it at first. And then we build the trust in the local levels, we build the trust in the middle, upper management, so on, step by step, until we reached at the top level of the ministry level to just formalize what was already a reality. So we had a different approach, but I think any country trying to develop One Health should start with the flagship disease, either be avian influenza, either be brucella, either be anthrax, name it. But start working on one disease, develop the concept, work together, and then eventually you will convince the top-up guys, and eventually you would come to a solution of a dashboard, which then would make your life much more easier to share information and to harmonize actions, because sometimes it's not easy to have joint action. But with a dashboard, you could have harmonized action. Each one does his own job, but then sees what the other is doing, and that means harmonizing and going together to stop the disease spreading. Thank you, and over.
Great, thank you. So as you can imagine, we have several questions about cost. So if anyone wants to share some perspective on what did it cost to build these dashboards, who's funding these dashboards, what is the long-term sustainability plan within your systems to maintain these dashboards? So I'll go ahead, Salim.
Thank you. So, you know, any program or project, or wherever it is in a country, the main contributor is the government and the people working behind it. But yes, you need technical support from international agency who are, you know, having experience and who have experts working in this field. So for us, the technical support was Ending Pandemics from USA. And you can see the gentleman, Mr. Mark, you have seen already Nomita, and there was a big team, Elizabeth and all others were the technical experts who were behind this success story. And government of Bangladesh through One Health Line Ministries contributed not only in terms of funding, in terms of human resource as well. So it's your objective and the long-term sustainability your plan. That depends where you can.
Hey, thank you. Kutum.
I mean, the cost should be break it down, I think, in two parts. And the development part, it could cost around, especially using open tools with the programmers and things, around to $200K USD. But it's also another component, which is the technical expertise. And that costs quite a lot, because that's the ideas and technical people which guide the IT guys. And that's more costly than the development if we wish so. But nowadays, the cost of technical expertise, it should be lower because we have here 5 countries which have explored the path. And a lot of solutions have been thought out, and these platforms are open source, so their code could be reused. So I think the cost is going down. More and more people developing One Health dashboards, the cost would go proportionally lower as we was in the beginning. We got a lot, for example, from PODD, which is the Thailand system for event reporting and then community-based surveillance. We learned a lot from them. And now everybody can learn from 5 of us here and get the idea. So this would reduce dramatically the cost of the expertise involved in developing a One Health dashboard, because ideas are already exposed and are free and are open sourced. So those are the costs in terms of our project. And of course, without the help of ending pandemics, we wouldn't be able to convince the government to invest in such an endeavor. But now we are in the process that the government is very much interested because it's seeing benefits. So the whole platform will be hosted into the e-government, which is this governmental data center. And therefore, all the maintenance, all security issues and everything, which are, again, costs, will be covered by the IT department of the government. So that's the security and the sustainability of such a platform. And the last issue that I would like to share is that these things should always keep evolving because we live into an evolving environment. So new ideas has to come. We have to learn more from each other. Something that was invented in Tanzania could be tweaked a bit and applied in Albania, and so on and so forth. So we are, although pioneers in this field, we are still eager to learn from whomever has good ideas. Thanks.
Great, thank you. Chane.
Thank you, Mark. The cost is a very good question. So to us, when we implemented the project, it cost around 200K. But I want to bring to here, for us, when we implemented the technical team, the software, the design technical team, they are local. They're in Cambodia. So that means the local cost in there. But we also, the cost in there included also the training to the 25 provinces for human and animal health, and getting that implementation for a few years. And I would say that from country to country, we need to be mindful that the copy and paste is not exactly the same, because we need to be very much thinking about the context of the user in that country. Even in Cambodia itself, when we do it between the human and animal health, we design the system with everybody, and then with subgroup, and then inside that, specializing it, making sure that it captures the context of each of the group that they wanted to have, while everything in the same name of the system. So it has to be very much, we very much pay attention into how we design this for the local context. And also I want to say also that for us, we're fortunate also to have the support from Ending Pandemic to design and deploy this system. And now both ministries are using it. The project is finished. The ministry both are using it in their own ministries, share the same resource to run it, the server and so on. But I want to also acknowledging thank you to the Ending Pandemic for when we build the milestone and metrics into the system. I must say that would not be possible without also the help from the expertise from Ending Pandemic, from Adam specifically, also, like, of course, like the team that help us, guiding us, help reviewing, providing feedback, and like kind of until we come out to the final system, of course with the local feedback, but also the expertise internationally also that bringing in here. Yeah, thank you.
Great, thank you. And Eric?
Yes, I think I share the same sentiments, but I also like to touch base on the sustainability component of that question. From our perspective, from SASIS, when we do the development, we have a knowledge transfer strategy that is incorporated in the developments, whereby it revolves around the collaborative approach of co-creation and co-deployment of these platforms. So this involves a close collaboration between the SASIS technology experts, also the epidemiologists, technical experts, and also with the national sector ministry experts from the initial stages of the design process all the way to the final stages. And the aim is to be able to adapt the technology to the specific context of that particular ministry or the particular sector. So that the collaboration also includes considerations such as the programming languages that are being used between the different technology programmers from the different sector ministries, the various frameworks, the workflows, the processes, also the technical teams stay in one room and hashing out the various ideas. And all through the entire process, we have we had a steering committee which was formed by the different sectors that are and different stakeholders in the creating the dashboard, so that they can they are actively involved in terms of reviewing, customizing, and also in the deployment of the technology. So with this approach, this really ensures that the local experts within the government agencies, within the sectors, also gains comprehensive knowledge and expertise in terms of being able to manage and deploying the platforms. So once you have a platform, and this really helped us in terms of when we were deploying the platform, you have the local or the experts from the ministries themselves manning the system. At the end of the project, they're manning the system, they're using the system, they're also the first line in terms of troubleshooting. And as technology experts or technical experts, we act as a second line of troubleshooting or support to the platform. So it really ensures the sustainability of the platform, even when, for our case, when funding, when the project ends and if there's no external funding, as we build ownership with the institutions itself, they also include in their budgets and the funding can continue with inside, but also they have also through the design process, they have the technical expertise to manage and back up the system. So I think when we're looking at sustainability, it really needs to be a collaborative approach so that at the end of the project, you have trained and personnel who can manage the system within the various sector ministries. Thank you.
Great, thank you very much. So we're coming up very close to the end of the session. So I think with that, I'm just going to thank the panel for answering all the questions that we could get through. I'll remind the audience that you have the email addresses of everyone in the panel. So if you have specific questions that you want to email people directly, that's great. I'm sorry we didn't get to many of the other great questions. If you have more general questions, you can feel free to email those to us at Ending Pandemics. Probably best to send them to Elizabeth at Ending Pandemics. And we can coordinate a group response if there are more general questions, as there are many we can get through. So with that, I want to turn it back over to Nomita to close out the webinar. But again, my personal thanks to the panel and for all of you out there who took the time to join us today.
Thank you, Mark. And so I want to give a heartfelt thank you to the panelists of this session and congratulate each and every one of you on spearheading and championing One Health surveillance through the use of One Health data dashboards. You truly are pioneers. We will make the recordings of this session available to all registrants and also posted on our YouTube channel. So please stay tuned for that coming to your inboxes. I'd also love to let you know that for those who found this session interesting, we have another session on November 15th, where we will hear from partners who have designed action plans for crowdsourcing disease surveillance through bidirectional engagement of communities. We hope you will join us for that as well. So with that, I thank each and every one of you for attending, and I close this webinar. Goodbye. Have a good day.